So thanks for joining. Again, my name is Stuart Menzies from CTC Communications. We're the company that helped execute and deliver on the PACE-MS program, the practice assessment, Canadian Early MS. For those of you just making sure you're in the right place, this is a training meeting to train you on the outcomes of the program so that you can deliver presentations in your local regions. I'm joined tonight by Dr. Natalie Parks, who will be presenting the data and sort of leading the clinical discussion. I'm really here to more facilitate the meeting. So just so everyone gets a chance to introduce themselves, it would be nice to do a little roll call. Maybe just say who you are and where you work. So some of you are muted, so just remember that if I call your name. So we have Dr. Karen Ho. Are you connected via audio now? Dr. Ho, can you hear me?
I can hear you. Can you hear me?
I can hear you now. Great.
Okay, perfect. Hi, sorry about that. I'm Karen. I'm a community neurologist in Ottawa, and I do see MS patients as well as other areas of general practice.
Great, thank you. Dr. Jachitsi, and sorry if I mispronounced your name. Can you hear me? Okay. We have Melanie Ursell as well.
Hi, I'm a neurologist in Bracebridge, Ontario, and I do 2 MS clinics a week.
Great, thank you. And Dr. Daniel Wong as well.
Hi, Dr. Daniel Wong. I'm a general neurologist in the North York area, and like Dr. Ho, I'm also I'm mainly a general neurologist.
Okay, great. Thanks. Dr. Parks, do you want to introduce yourself just briefly?
Sure. So I'm Natalie Parks. I'm a neurologist at Dalhousie University in Halifax. I actually just recently started on staff here about a little over a year ago now. I did a fellowship in multiple sclerosis and demyelinating disorders at Mayo Clinic prior to returning to Dalhousie, which is where I've done all my prior training, and Halifax is where I'm from. I mainly practice in multiple sclerosis. I do 4 to 5 MS clinics a week, so I see a lot of MS patients. And yeah, it's great to be joining you tonight.
Perfect, thank you. So just quickly, a couple of housekeeping notes. If you haven't already, please sign the contract you received from Ashley Folkert. She would have sent it to you. It's a contract between yourselves and Biogen. It can be DocuSign, and the contract covers the training meeting as well as the sessions that follow. So please sign it if you haven't already and send it back. And just another note, the meeting is actually being recorded for those who aren't able to attend any of these 3 training sessions. So back to the program. So the PACE-MS program was put together by a faculty consisting of the people you see on this slide here. So we had Dr. Stephen McKenzie from Mississauga, Dr. Natalie Parks, who you've met, Dr. Letitia Murazan from Quebec, as well as we had a nurse practitioner, Margaret Proshuk, involved in the program as well from Edmonton. And the objectives really were to map the current treatment landscape in MS in the first-line setting and understand the profile of MS patients being treated with first-line DMTs. Also looking to determine the drivers influencing choice of DMT along the treatment pathways. And really, we tried to get at this in 2 different ways through the PACE-MS program. The first was that there was an HCP profile that you all completed as well. So 33 neurologists completed it, really to understand sort of your baseline practice patterns. Second, we asked you to assess MS patients on their first-line DMT, and that was done for 314 patients. So what we end up with is a pretty rich data set of how neurologists are treating MS in the first-line setting across the country. So I'm going to turn it over now to Dr. Parks to present the data from the HCP profile, which, again, as a reminder, this is what was completed first and really is to just provide us with a baseline to understand who took part in the program. Dr. Parks, go ahead.
Great, thank you, Stuart. So as you heard from Stuart, this was basically a survey of neurologists like yourself from across the country. There were 33 neurologists who participated in the survey, and it really was in two parts. So there was the first section that was, theoretical situations about what would you do, and then following that there was a practice audit to look back through patient charts and determine what was actually done in the treatment of, it was about 10 patient profiles that each participating neurologist contributed. So of the 33 neurologists who participated, just trying to advance the slide here, there we go. Who were those neurologists? Where did they practice? What sort of practice were they involved in? The majority of the participants came from central Canada, so Ontario and Quebec, with a few on the East Coast and West Coast. So there really was broad representation from coast to coast across the country. Many individuals who participated said that they were involved in a solo practice, they basically, even though they were in a solo practice, many of them considered themselves MS specialists, and by MS specialists, the majority of participants saw more than 10 MS patients a month, so it kind of broke down in thirds between whether they saw 10 to 24, 25 to 49, or more than 50 in the run of a month. Despite the fact that two-thirds felt that they were MS specialists, not everybody had the support of a dedicated MS clinic behind them. Only about 40% had a dedicated MS clinic, but the majority had at least nursing support some of the time, which is really important with prescribing and monitoring these drugs, because there can be quite an involved process in terms of navigating the insurance coverage and then following up on test results. So very helpful to have a nurse involved with that process. And so in terms of the theoretical cases, the first case involves someone that, I would typically see in the MS clinic, so a 27-year-old woman who presents with an episode of right optic neuritis. Her optic neuritis was treated with IV steroids for 3 days, and she recovered pretty much completely from that episode. As part of the history, you also get that, there's another episode of some facial numbness about a year ago, and that completely recovered as well. On the neurologic exam, there, were subtle hints of prior right optic neuritis, but she'd recovered fairly well. Her MRI showed some characteristic lesions consistent with demyelination. They were all supratentorial lesions with 6 lesions distributed in the juxtacortical and paraventricular regions, and she had no spinal cord lesions. So overall, based on that, but the dissemination of symptoms and imaging, we get the dissemination in space and time, and excluding other potential causes for this. The diagnosis is relapsing remitting multiple sclerosis. Then the next process would be to determine the therapy for disease-modifying therapy, and she tells you she wants to be really cautious about the treatment, with one of her major considerations being that in the next few years she'd like to start a family. Is there a way, I see that someone raised their hand. Is there a way to ask them to ask their question?
No, that is me. I was actually testing the icon. Sorry.
Fair enough. Fair enough. But let me know if you have any questions, because feel free to ask.
I'll do that.
So, In terms of what neurologists who responded to this survey felt would be a good first-line treatment for Katie, almost half suggested that Copaxone would probably be the best option. 21% suggested Tecfidera, 12% suggested Aubagio, and I guess if we combine Copaxone and Glotec as the glatiramer acetate options, it's over 50%. And if we combine the interferon options, that comes to 6%. So Copaxone was far and away, you know, the medication that neurologists responding to this survey felt would be a good option for Katie. And so looking at the reasons that that medication was selected, so you can see here along the kind of y-axis of the chart, those are the reasons for why the medication was selected, followed by a sequencing of the most common to the least common therapy, and looking at the percentage that neurologists responded that played into their decision-making of why they selected their first choice of drug in this case. So looking at glatiramer acetate, which was the #1 choice, it looks like most participants responded as they did because of the piece of information that Katie was planning a family over the next couple of years. So 78% they felt that family planning played a major role in their decision to select glatiramer acetate. 17% also used the piece of information that Katie has what would be considered, I guess, milder disease. So they, in terms of assessing disease severity, I guess they felt comfortable prescribing Copaxone or suggesting Copaxone because she had milder disease activity. Looking at the second most common option, so dimethyl fumarate. So in terms of the most common reason that dimethyl fumarate was selected was related to mode of administration. So certainly, you know, a lot easier to take than an injection. Dimethyl fumarate would typically be taken twice a day as a pill. So it's a lot more acceptable to a lot of individuals than taking an injection on a regular basis. Also looking at other reasons why dimethyl fumarate was selected, so 29% selected it because of family planning, and you know, I think that's reasonable. Typically in my practice I would suggest a 3-month washout period before trying to conceive. But again, like with that 3-month washout period, certainly it's a good option for women who in the future, not necessarily right away, but in the future are planning a pregnancy. And 14% selected it due to efficacy because dimethyl fumarate has been shown to reduce relapses by about 50% compared to placebo. And you know, that's compared to glatiramer acetate, which in some of the randomized controlled trials has been shown to reduce relapses by about 30% compared to placebo. So even though comparing a little bit of apples and oranges because they're different studies, but perhaps a little bit of edge in terms of efficacy for dimethyl fumarate.
Dr. Parks, could I just ask a question? Is this
Sure.
what we're going to be? Is this what we're presenting? Like, I'm just confused.
Yes, so these would be the results of the survey that are going to be presented.
Okay, so this would be a part of what we would be presenting to neurologists.
That's right. Yeah, it's. I guess it's basically so the survey was sent out to everyone, and among those that responded, it's kind of the way that neurologists responded to this scenario. So what was the medication they thought would be the #1 choice in their mind for what they would recommend, and then what were the reasons behind that decision.
Okay.
Yeah.
And let me jump in for a second and start again. Apologies if I didn't set that up enough for you. Really the intent is to help share the results of the program and disseminate it further. And part of what we're going to get at the sort of end of the presentation of this is what else do you think we could add to this to supplement it. So it's less about just the data of the program, but maybe there's things that you like to present when you give talks or you think would be interesting, like support discussion with your colleagues or strategies for patient conversations, anything like that. So maybe as we're going through, keep that in mind and we can have that conversation at the end.
Well, I certainly have a lot to say about the Copaxone.
Feel free to jump in.
Yeah, please share your input.
No, I mean, I wouldn't prescribe Copaxone, and I'm a little shocked at the percentage that would recommend Copaxone as a first-line therapy for someone who is planning to have a family in the next few years. I would treat her MS with the strongest possible agent I could in the moment to get her stable, because we know early treatment is most important. So I guess it would just generate a discussion around the possible downfall of prescribing Copaxone, and you know, things about if you do have 3 months off therapy before someone is pregnant, there's a good risk of relapse in that period. So I think it brings up the whole discussion about how to manage patients before pregnancy as well.
Oh, for sure. And I mean, keep in mind that this is the results of the survey that the neurologists responded to. So it's just a sample of the neurologists that responded. Certainly, there's a lot more than 33 practitioners across the country who treat MS. So it is sort of a small sample who responded, but many people who regularly see MS patients. That is, I guess, their current practice to consider Copaxone in that context. But I agree with you that, you know, planning a pregnancy in the next few years, there's certainly a lot of other options out there, and I certainly wouldn't feel limited to prescribing Copaxone to someone based on that. And I agree with you that you know, the first few years of MS can determine the long-term course. And it's important to treat the patient in front of you, and certainly a pregnancy over the next few years wouldn't be limiting to the majority of treatments that you could offer. So in terms of, I guess, the discussion that comes out of those survey results is what information is available that would cause you to select Copaxone for family planning. So I guess number one, as you were saying, to limit yourself to Copaxone because of family planning because of a pregnancy over the next several years, that wouldn't really be necessary. Certainly there's no medication that really has a seal of approval as being safe during pregnancy. Of any of the medications, Copaxone has the best evidence for no detrimental effect if it is used in pregnancy, and some practitioners do choose to continue it through pregnancy. Many of the other medications, at least according to the American pregnancy drug categories, Copaxone would be a category B, so that would be a medication that hasn't been shown to harm in pregnancy, whereas many of the other medications are category C, which is sort of inconclusive evidence. Whereas Obagio is a medication that's been labeled category X, so demonstrated effects of harm among the first-line agents that we're discussing this evening. So for many of the medications, it is possible to use them leading up to a planned pregnancy. For many, typically there would be a 3-month washout period just because they don't have that demonstrated safety for use during pregnancy. So for example, the interferons or for dimethyl fumarate, typically I would recommend a 3-month washout period prior to attempting to conceive. At least that's my practice. In terms of teriflunomide, that medication has a very long half-life, so it still would be possible to use for someone that was planning a pregnancy in the future, but there would be the issue of doing the accelerated washout prior to conceiving, and that would be with the 11-day course of cholestyramine. I guess, does anyone else have any comments that they'd like to bring up?
So are we going to have, can you interject slides that review the safety of these various EMDs in pregnancy and the data in terms of pregnancy registries? Is that going to be a part of the presentation?
I think that would be useful. It's not part of the current presentation, but I think that would be useful information to present. I think we could probably add something to that effect.
Okay, and I guess the only other comment I would make is that I don't think I would wash anybody out from interferon because there's a lot of accumulating evidence that it's quite safe, even in pregnancy most likely. So to prevent relapse and disability, I'd probably continue it right up until they became pregnant.
Mm-hmm. And I mean, there's certainly variation in practice with that, and you're right, there's increasing evidence that interferons aren't associated with an increased risk of congenital malformations, and that there is accumulating evidence for not being harmful in that context. So I guess there is some variation in practice, and you know, that seems you know, it certainly can discuss what your own practices, and clinical experience are. Does anyone else have any
information? Sorry, I just wanted to jump in on that point. If this information isn't, you know, widely accessible, I think it would be very useful to include some of this if it helps with your discussions with your colleagues.
Yeah, I think this is all very controversial. So that might be helpful.
Okay, great.
And I think that one of the main objectives in doing this survey was to get a snapshot of what the individuals who responded are actually doing in their practice. So I guess it's helpful to capture what neurologists across the country, at least those who responded to the survey, are currently doing, and then discuss those results and stimulate discussion among colleagues to share knowledge and the practice of what we're actively doing in treating patients. So there is going to be a little bit of variability from practitioner to practitioner, and I think that all of this is really good for stimulating discussion about what we do in our own practices.
Can you hear me?
Yep.
I'm sorry, it was like a pause there, and I think I muted myself unintentionally. Drug educate here. So I'm surprised that the teriflunomide choices as a first choice for this woman, given that you know is interested in obtaining a pregnancy and having a childbirth in the next few years. I mean, as you know, the half-life is quite long, could be up to 2 years, and even if you do elimination, not all patients tolerate elimination. I have patients who could not tolerate cholestyramine. Obviously, that's something you know ahead of time.
It can be very difficult
to
tolerate.
Exactly. So I had people that could not tolerate it at all, no matter how you slice it. So you could run into those trials. It's not as easy as assuming you can just eliminate it.
I guess.
I'm sorry?
A lot of distress by potentially putting them on a medication that if you don't wash it out, it will be in their system for years, significantly delaying their plans to have children, or putting them through what could be a distressing washout procedure that, you know, some people, even with coaching through it, can't tolerate. So I agree with you. I tend to avoid teriflunomide in young women where pregnancy would be an issue over the next couple of years.
Right. The other thing is, I think that 50% of people choosing acid is probably use of the first-line therapy in someone who's young who probably has a risk of getting pregnant. yes, they plan to get pregnant in 2 to 3 years, but they may get pregnant earlier on. And yes, I agree with Melanie that first year terribly important to suppress the disease. But again, if this patient follow extremely closely, and so in 3 months, 3 to 6 months, you do an MRI, see very hot MRI, should they have another relapse, then you can move very quickly to very potent therapy that, you can treat them early and you treat them aggressively, and after 2 years, they can get pregnant. So I think there's an open forum for these discussions, how and what you started with, but more importantly, how closely you follow and what your next steps will be, and how rapidly do you escalate if they show active disease activity, if you put them on a less potent drug like Copaxone versus Tecfidera, for example.
So, I mean, so in terms of if fail that kind of less aggressive first-line therapy, then using that as the platform towards an even higher efficacy therapy beyond one of the first-line agents, and that certainly can be a strategy as well. All right, so moving on.
You guys are cutting out.
Yeah, I think your audio is cutting out a little bit as well. It's not coming in as clearly as it was.
So moving on to case 2. So this is a 36-year-old man who presents already with a significant amount of disability. So he presented to the emergency department with what sounds like symptoms of ataxia. His walking was unsteady. He worked as a construction worker, but was unable to work on a construction site anymore due to imbalance. And less than 6 months previously, he had symptoms in his left leg like weakness and stiffness, suggestive of upper motor neuron on exam. And so when you examine him, he already has an EDSS of 3 with evidence of upper motor neuron findings affecting his left leg, and evidence of ataxia as well. So his MRI of the brain showed 15 demyelinating lesions, including 1 gadolinium-enhancing lesion, which was actually in the pons, along with another cerebellar lesion. So this time there's a gadolinium-enhancing lesion and infratentorial lesions as well. There's a lesion in the spinal cord. So this patient, he's eager to start therapy, and he presumably wants something that's going to control his disease. So when neurologists were asked what would you choose for this patient among the options you can see on the y-axis, 64% in this case chose Tecfidera, 24% selected Tysabri, 6% one of the interferons, and 3% chose Copaxone.
So why was Tysabri an option?
Yeah, exactly.
Second line? Because you haven't included Lemtrada, Mavenclad, Ocrevus. This is kind of unfair. It's not balanced. So I'm just wondering why Tysabri was a bunch of first line.
I think in Quebec you can use Tysabri as first line, I think.
Pardon me?
I think in Quebec you can use Tysabri as first line.
Yeah, right, but only Quebec. So.
Yeah. Because they included in the survey.
Yeah, I just wonder why it was included without any other second line being included.
Yeah, you're right, because
really, Tysabri should be, for this fellow, it should be 100% if it's available to first line.
Right, I mean, certainly I would very strongly consider Tysabri from the available options for this gentleman. In fact, I saw someone today.
Right, but if you consider Tysabri, you can consider all the other second line, so he could just as easily go on Lemtrada or Ocrevus. So that's what I don't think it's a balanced slide. So
just a technical point here. We did not include Tysabri here, but so many people wrote Tysabri in the other category that we broke it out separately. So we only included the ones up to Tecfidera that you see, but so many people wrote Tysabri that we ended up including it. We only were including first-line agents in this to begin with.
So it wasn't offered as an option, and they still chose it.
Correct. They wrote it in under other.
But they chose no other second-line therapy.
There were a few. You can see there's a 3% selected other, but that's very small because 3% of 33.
Okay. I just think it's
I'm surprised why Ocrevus as a first line, because approved as a first line, and some insurance companies now are covering as a first line, which was initially a problem, but Ocrevus was approved as a first line.
Mm-hmm.
So why not on the slide? Because technically it's approved as a first line. Insurance companies have been denying it. You need to build something else, but that's their choices. But now some insurance companies are starting to cover it as it's been intended to be used as a first line. I just wonder why it was not on the slide, because it's actually approved as a first line therapy.
Should have been allowed to come into play in this slide at all, because you know, it looks like if they picked Tisabri and no other second line, it looks like they were aware that this is a Biogen-driven program. It's just, there's glaring abnormality about this slide. So,
I mean,
if
certainly,
this is a first-line presentation, it should have been a first-line presentation. That's kind of like cheating.
I certainly take your point there for sure, and certainly Ocrevus, even in the product monograph, as you say, can be used first line in Canada. The COMPASS program certainly facilitates Ocrevus being used first line. I think what Stuart is saying is they saw, like, the way the question was presented was everything up to Tisabri was presented as a multiple choice option. And then there was the option for other, and quite a few people wrote Tisabri from what Stuart's saying. But I guess one way to reduce bias in this could be to maybe take the Tisabri out of the graph, incorporate the, so that would be 27% that would have selected other, and then give a breakdown in kind of a legend on the side saying that the numbers that actually selected Tisabri versus what the other choices there were comprising the 3% that are currently listed.
That would be better. That would be more balanced. And I think I would also make the point that those 24 may have come from Quebec. And so that would explain it, right? So if you take away the Quebecois, then maybe it wouldn't be there because it's not first line in the rest of Canada.
Right, and you're right. I mean, 30+% of the respondents came from
Quebec.
Yeah, a big factor.
So I think that just needs to be a qualifier here.
Yeah, and I agree completely. I think that we should take the Tisabri out, incorporate it all under other, and then have a breakdown on the side of what the numbers were comprising the other.
I think that's a good idea.
Sure, we can do that.
Well, Natalie,
I'm sorry, I still don't.
Oh, hi, Greg. Hello. How are you?
Very good. I will say that historically, for high-intensity therapy, Tisabri was the only one available in Atlantic Canada, which the company provided compassionate relief for. So in Atlantic Canada, at least historically, that's why if people answered from Atlantic Canada, that would be their answer because that's all they had.
From a perspective, for sure. I mean, that came out in 2007, and many agents, higher efficacy agents, weren't, like there was an interval of time when there was no other high efficacy medication.
Exactly.
And it's not that it's not a good choice. It's a great choice. Like I said, there should be 100% saying he should be on that drug. But the title says first-line treatment. And so kind of allowing people to cheat. And
well, we used it first-line treatment for people that were very ill. They got first-line treatment with it.
But that's not the point I'm making. The point is that it looks like it's a sore thumb sticking out, and this is a Biogen-driven thing, and there's Tisabri, and there's no other second lines mentioned, and why are people allowed to pick Tisabri when in most of Canada it's not a first line? So if you'd have to say, let's say it's utopian and you've got coverage for everything, what would you pick? Or you have to follow your guidelines in terms of what
the question wasn't about guidelines. The question was which would you follow? So people would do what's based on their clinical practice. That's what they do.
Well, then you need to.
I mean, that's it. It's not about
then you need to show how many people were on Lemtrada. Then you need to show off the Lemtrada, Mavenclad, and all the others.
Yeah, no. Well, eventually we did that, but People are answering based on history.
Yeah.
And I take your point that the majority of this survey focused on all of the medications up to Tecfidera. So most of the responses would have had multiple choice question with all of the options up to Tecfidera listed, and then coming after that would be other. So it would make sense to combine the Tisabri into other, but then have a breakdown of within other what individuals chose, because maybe as first-line therapy, even though it's not really considered platform therapy, you can still have a high efficacy therapy that you use first line for aggressive onset MS. And certainly even today in clinic, I mean, certainly first, I was using high efficacy therapies for individuals, just like the gentleman described in the case scenario. So for someone experienced in treating MS, they might read that scenario and say, none of those platform therapies are appropriate. I want to choose something different than that. And those are the individuals who probably selected other and then selected the high efficacy therapy that they would choose.
Right.
Precisely.
But I know that, I saw a gentleman in clinic today, very similar to this case scenario.
So the argument is not that you wouldn't put him on a second line therapy as his first drug. I would do that. I would consider
I take your point. You just want to make sure that the way that the information
is not balanced, because you've got this Tisabri outlier. It could be just because it's first line in Quebec. You have to mention all the others, because if you're arguing that his MS is bad, which it is, it's very bad, and that he should be on a stronger second line therapy, then you have to give equal weight to all of them and say, if we're allowing you to choose a second therapy, if it's funded compassionately or we can get him on it somehow, then you need to mention all of them, because any of them would be appropriate for a patient with this kind of MS as a first treatment. That's all.
I think in the interest of time, let's move on from this discussion. We have quite a few slides to get through still, and I think everyone gets the point.
Can I interject for 1 second?
Sure.
Yeah, I think, to clarify that slide that we just went through, I think the confusion was, what's available and what you use if everything was available, number one. Number two, a bit more, I feel a bit of bias in this slide that Ocrevus is not included, because it is listed as a first line. I think it has a great efficacy. So I'm surprised that was not listed, because that's approved at least as a first line therapy. So I think she should have been on this slide as an option.
Exactly. Right, and like I was saying, I guess the way instead of line so much, maybe the options that were listed as the multiple choice responses were more so platform therapies. And some practitioners read that stem and said, this is not a patient appropriate for a platform therapy. I'm going to choose other, and then they wrote in what they would choose, and that was free form. It just so happened that many of them chose Tisabri, but I think that because that is the way the information was collected in an other category, we should present it as a collapsed form of other in the graph, and then maybe break it out in a side panel saying this is the number that said Tisabri, this is the number, but break it down in terms of what the actual written responses were, because there's 3% there that chose something else. And maybe one of them chose Ocrevus, maybe it was Lemtrada, I don't know, but I think that we could collapse the graph into reading other, and then break out what the actual typed responses were, and I think that would probably be more balanced and be a better reflection of the way that the question was posed.
With a qualifier that 30% of respondents are from Quebec, and they do have first line, and that's probably why it was favored.
So I don't know that you can say. I mean, we know that from the demographic data, but if we were just to put down what the numbers were, that would be a reflection of how the question was asked and what the responses from the participants were, knowing their demographic. So the next question was indicate the primary reason why the medication was selected. So in this case, it was the choices were made. Neurologists recognized that Phil had severe disease, and tying into that, wanted an efficacious and more efficacious therapy. So that's not really a surprise that in this scenario, those would be important factors. So I think we've already touched on some of this. But I mean, I think we've already discussed the two cases and identified there was certainly discussion around why the treatments that were selected may or may not be appropriate. And one of the main controversies with case one, the young woman, would be, you know, should the fact that she wants to become pregnant over the next several years influence decision-making? Well, we do know that early effective treatment is beneficial in delaying long-term disability. So the fact that she wants to become pregnant over the next several years shouldn't really be limiting if she's not imminently planning a pregnancy. The issue with the second case was really, is this even a good candidate for platform therapy, or should a higher efficacy therapy be considered in this individual first line? So, and any other comments before we move on from the cases? So as a freestanding question, the next question on the survey was, in the past year, what if, as a first-line therapy, what do you think your first choice of first-line therapy has been over the past year? So the medication that you would maybe prescribe most often for platform therapy for patients among the medications listed. So in this case, 46% of individuals responded that they thought their number one first-line or platform therapy would be Tecfidera. 27% responded Copaxone, and 24% responded Aubagio. So that's just a reflection of, with that question, what neurologists who responded felt their choice of first-line therapy would be, just in a very generic way. Someone had a question?
No, just shock. I can't believe Copaxone and Avonex are in the top 4.
Well, I agree that I mean, some of the efficacy data on Copaxone is certainly not as robust as some of the other medications, but practicing, or I did my fellowship in the U.S. just a year ago, and it's amazing that in the United States, Copaxone remains one of the most frequently prescribed MS medications, and there's some thought that that might be due to the ease of monitoring. I mean, not that it's something that I would advocate for, but I think that a lot of clinicians who maybe either don't see a lot of MS patients, maybe they don't have a lot of MS nursing support. Maybe Copaxone was one of the main medications available when they did their training, a variety of reasons, but it is a very easy medication to use. There's essentially no monitoring that's required with it, and I mean, I think that in some cases makes it an attractive choice for some neurologists, and maybe a seminar like this, which stimulates discussion about what the other options are available, would be helpful in maybe changing their practice, and maybe with the increased information, maybe there'd be the opportunity to advocate for some more nursing support to maybe help them with the process of both prescribing and following patients who are on some of the more labor-intensive medications to monitor. But I agree with you. It is somewhat surprising, given what we know about the spectrum of efficacy of the different medications, that one of the medications that's known to be less efficacious is still among the most prescribed of the MS medications. And so I think there's a number of factors behind that, but perhaps educational initiatives will be helpful in changing practice and maybe shifting towards a more aggressive treatment approach.
Which is the point of the presentation, really.
Mm-hmm. And so this was a question to ask at what interval are MS patients followed up after starting on a first-line therapy. So for the majority of both mild and moderate disease activity patients, neurologists were following up around the 6-month mark. For higher levels of disease activity, many were being seen within 3 months, and for milder disease activity, a number were also following up at 12 months. So I don't think that's too surprising. I would see many of my moderate activity patients, I guess if it was severe disease activity, maybe even 3 months, moderate 6 months, and some of the less severe going out to 12 months. So I think that's a fair reflection of my practice regarding follow-up. All right, so now we're moving into the part of the program that was the chart review. So this took information from 314 patients, and this information was supplied by the 33 neurologists who responded to the survey. So patients that were included in this survey were started on their first MS medication. It needed to be one of the medications listed, so basically platform therapies, and that medication had to be started within the past 2 years of responding to the survey. So the average age of patients included was 38. About a quarter were male, meaning that 3/4 were female, so a little bit, probably a higher ratio of females to males than what we see, which is typically 2 to 3 to 1. But nevertheless, there was a spectrum of how long ago MS was initially diagnosed, with some patients even being started on their first disease-modifying therapy greater than 5 years after initial diagnosis, which seems like a long treatment interval today. I mean, potentially a number of years ago that would be typical, but today it's somewhat surprising that 9% of patients included in this chart review who were diagnosed within the past, or were started on a medication within the past 2 years as their first MS drug, waited more than 5 years to start therapy. But I guess there could be other extenuating circumstances to that. For some people, maybe they were, family planning and had several children over that time span, which potentially could be one mitigating factor. So responding another way, how much time passed between diagnosis and the initiation of treatment. So once the decision was made to start treatment, over 60% of patients were started on treatment within, or over 70% of patients were started on treatment within 6 months. So 25% within the first month, with another 48% between 1 and 6 months. And I would say this is probably also a reflection of what happens in the MS clinic here, where many patients are started within the first month, but there's a lot of preliminary testing, investigations, and insurance paperwork that needs to be done prior to actually getting the first dose of the medication. So it's not uncommon to go past 1 month in the 1 to 2 month range to get all the baseline laboratory investigations, if someone needs immunization, to update the immunization status, and to sort out the immunization coverage, or the insurance coverage. but certainly that should be done well within 6 months.
Well, as you know, Natalie, the treatment decisions are not made strictly by the neurologists. They're made in concert with the patients. This is the same reason that Copaxone had such a high market share, was the whole safety issue, that it was safe. If you mentioned PML or anything, people would retreat to Copaxone. And the same thing happens with a number of patients. They don't want to start anything because they're nervous. You know, some of the patients we've had, and you have to kind of not browbeat them, but kind of convince them into it by showing them their MRI has progressed and so on. So it's not always as simple as the neurologist thinking that this is what you should have. It's always done in concert with the nurse and the patients.
Oh, for sure. And I mean, I think we'll get into that a little more with some of the later information from the survey, but I completely agree. It's a shared decision-making process. And, you know, often I think neurologists have one thing in mind and patients have another thing in mind. And really it's the discussion where you meet in the middle and decide how you're ultimately going to go forward.
Exactly.
It's definitely a process, and there's quite a few factors that go into it. Just in terms of, you know, what factors influence the time between diagnosis and treatment. So sometimes it's low disease activity, might be insurance issues. As you were saying, Greg, you know, 38% of the time, you know, it's patient preference actually not to start therapy, and that's responsible for a delay. Sometimes it's testing requirements, updating the vaccination status. So there's a broad range of what goes into it. But if you wanted to pick the single biggest reason why treatment is delayed, it's actually you know, at the request of the individual who has the disease, that they're just not ready to start on something yet, even though there's good evidence for that. Some people, for whatever reason, they're in denial or they're scared of some of the effects of the medication. So I guess you have to kind of approach the person where they are and meet in the middle and hopefully you know, hopefully help them see the way forward with what we know are effective strategies in controlling the disease long term. So this is another question that was asked because we often do a lot of baseline testing, and here most patients do get a TB skin test prior to starting therapy, which sometimes can contribute to the delay. And with certain medications, it's certainly important to exclude you know, tuberculosis infection, but turns out that 88% of people among the group that were surveyed in Canada did not have exposure to tuberculosis. So is it important to do a TB test on everyone? I think it's helpful information to know in case you do need to switch to another agent quickly, because sometimes if you've been on an immune suppressing drug, that does actually affect the results of at least the TB skin test. Although there are other ways to test for TB, like the quantiferon test, which would be less affected by being on immune suppressing drug. In this survey, 60% of the patients had a monosymptomatic presentation. So we only asked for patients who were started on one of the platform therapies, so glatiramer acetate and interferon, or teriflunomide or dimethyl fumarate. So that could be one of the reasons why 60% are monosymptomatic, with fewer individuals having a polyregional syndrome, which of course is associated with a more severe presentation of disease. It might be something that would influence a treating neurologist to lean towards one of the more higher efficacy therapies.
That seems very high, doesn't it? For almost 40% presenting with.
I mean, It does. It does for sure. I mean, certainly it's a red flag to me if someone has a polyregional syndrome, that this might be a more aggressive presentation of disease and to consider one of the higher efficacy therapies.
It's just if you take all new diagnosed patients, that seems like a very high number that would present with polyregional syndrome.
It does. I agree with you.
Or something. Yeah, it's interesting.
And I'm not sure how. I'm not sure because I don't think I guess it was somewhat at the neurologist's discretion how they made that determination of.
Yeah, they may have been picking more active patients for the survey.
And that as well. And so we've already touched on this a little bit, but so how does the 60% with a monosymptomatic presentation fit with your practice? So that actually, as we were saying, I mean, it seems high that on the flip side of that, almost 40% would have a polyregional syndrome, that we would expect maybe a higher percentage to be presenting with monosymptomatic presentation. And in terms of 73% of patients treated within the first 6 months of diagnosis, I mean, that seems to me about right. It may be a little bit on the low side. I mean, certainly there is the factor of patient preference and readiness to start therapy that some patients, even after discussion of the benefits of how therapy helps with the long-term risk of relapses and even promising, very promising information that, this helps disability in the long term if you treat early and get the disease under control even within the first year. Some patients are reluctant to start therapy. So I'd say 73% within the first 6 months starting therapy, maybe a little bit on the low side, but certainly there are individuals out there that, regardless of the counseling, are hesitant to start on one of the MS therapies. Any other comments about that?
Just that I think time from first symptoms is important too, because a lot of these patients wait a year or two to get into an MS clinic to get treated, but they actually have MS already. And if they go to the clinic and at that visit they're being diagnosed and it's being confirmed and then they're starting on treatment, that's a different.
So it all adds to the delay in actually.
So really these patients are probably not being treated as quickly as we think they are because they're waiting.
Oh yes, I agree for sure.
Right? Yeah.
So to clarify this, 60% seems low to me to initiate therapy in 6 months in patients with MS. Did this survey include only the patients who a neurologist who initiate treatment, or neurologists who diagnose and then refer patients somewhere else, like a MS clinic, to initiate treatment?
So
you
you're
understand my question, Natalie?
Yeah, so you're asking, I guess.
If the survey has been targeting neurologists to treat MS who also initiate the treatment, any treatment, or neurologists who diagnose MS but refer patients somewhere else to initiate treatment.
Exactly.
To me, that potentially could extend the lag.
Yeah.
I think the way the question was posed was they wanted to definitely only include patients that have been diagnosed with or who had started the therapy within the past 24 months, but there wasn't a qualifier as to the duration of time between diagnosis with MS and starting therapy, and I don't think the information was collected about whether it was the same neurologist that diagnosed MS and started the therapy, or whether there was a delay because the diagnosis of MS was made by one person, someone else actually needed to start the therapy. I don't think that information was collected. But again, another important factor that if someone was, diagnosed in a hospital potentially with MS and then waiting to get into an MS clinic to start therapy, that could certainly delay how long it takes to start treatment. Yeah,
some of the MS clinics have a waiting time like 1 year, for new patients. So that could potentially explain the low numbers, 70%.
Mm-hmm. And that's an important consideration as well. But certainly, I mean, I wasn't in practice 10 years ago, but it certainly seems, you know, certainly the availability and the information we have now about the importance of disease-modifying therapy, I think, is a lot better known. And I think there's much greater uptake of starting MS patients on therapy, and probably the interval to diagnosis to starting therapy has dramatically decreased over the past 10 years. Any other thoughts on that? Okay, so just in terms of what sort of assessments were done for patients, so 98% of patients had an EDSS score recorded, which even though it's not a perfect measure of disability, it is, I would say, the most standardized form of recording disability in multiple sclerosis. And it's certainly something that I keep track of at every visit, and I do find it helpful to look back over time how it's progressed. I mean, one of the notable weaknesses of the EDSS would be that it's very heavily motor focused without as much focus on upper limb function or cognitive ability. But again, it's very quick to perform. I mean, it's part of your regular assessment. It's something that's been tracked over a long period of time, and it's generally recognized as I guess the most standardized form of measuring MS disability. The symbol digit modalities test is a measure of cognition. It's also a fairly brief test to administer, but does require a little bit more organization in the MS clinic to be able to perform on a routine basis. Only about 12% of patients who were included in this review had the symbol digit modalities test performed. In terms of what other assessments were being done on patients, so many neurologists were doing an informal depression screen, but still 44% of patients weren't assessed for whether they were having depression. Many patients, not surprisingly, complained of fatigue. Either this information wasn't collected or they specifically denied fatigue at the time of treatment initiation, so 33% either, I guess it wasn't known or they specifically denied it. In terms of other comorbidities that are affecting MS patients, so you know, the most common situation actually was to have none of the above listed comorbidities, which is somewhat surprising that 50% had no other comorbidities. But as you know, anxiety and depression are very common with multiple sclerosis, and not surprisingly, a significant percentage of patients had those conditions. Also, 9% used tobacco, which of course is associated with increased disease progression. In terms of whether family planning was an issue for the patients included in this, surprisingly, even though 3/4 were female and the average age was 38, 76% indicated they were not planning a pregnancy. So I guess the vast majority of patients that wasn't an issue. Only 9% of patients were planning a pregnancy in under 5 years, and 13% of patients were planning a pregnancy in quite a bit down the road, in greater than 5 years from the time the treatment was initiated. So certainly, I mean, in a case where pregnancy isn't imminent, then I don't think there's a need to limit therapy as a result of a pregnancy years down the road. Were the patient's immunizations confirmed to be up to date? So about 40% of clinicians were checking into immunization status. I guess for 25%, they weren't up to date, and I guess a number of other physicians weren't checking on that. And I think that's become an increasingly important issue in recent years, is addressing vaccination status from the outset.
So what is
because once someone gets initiated on an immune modulating therapy, it is much harder to update vaccination status. So if there's the opportunity to be able to do vaccination before immunomodulatory therapy is started, that may be the best time to update varicella or MMR or a number of other of vaccinations that might become an issue down the road, particularly in young women checking for rubella status if they are going to have a pregnancy, you know, years down the road. You know, it's important to be immunized against rubella for future pregnancy.
What is the list of immunizations that are being confirmed to be up to date? So I know the question asked that, but do the responders have a specific list that they're checking off? Because I don't actually know what this list is. What is this list that we're confirming to be up to date? Because there's really
and we didn't, I guess, you know, there's no standardized list. I guess there's no gold standard of what would be.
So a responder may just be thinking of one thing, like Zostavax or something. So it would be interesting to know what this panel is that people are considering as being up to date.
And that's true. We didn't collect that information from the respondents, but I can tell you that in the MS clinic here, we check for measles and mumps, or sorry, we check for measles and rubella. We check for varicella. We check for all the hepatitis, so A and B, basically. We also check C, but for an unrelated reason, since there's no vaccine. But those would be the immunizations that we're checking. So I'd say rubella would be particularly important for young women because if they're not immune, that is something that is important prior to pregnancy, and it's a live vaccine, so very difficult to administer once someone gets started on an immune suppressing therapy. With varicella, I guess, you know, some medications, it's important to confirm varicella immunity prior to starting that treatment. So none of the first-line therapies really fall into, or none of the platform therapies really fall into that category. But something like Gilenya, I would like to check varicella status before starting that medication. And for hepatitis A and B, I mean, that's something that some people want to have immunity for, either because of work or travel, and that's an inactivated vaccine, so it's a little bit less restrictive than one of the active vaccines. But again, giving even an inactivated vaccine on an immunomodulatory drug, it may not have the same risk associated with it, but it, you know, the vaccination is less likely to take effect. It's less likely to be effective if someone's immune system is suppressed. So for me, those are some of the things that I check up front. So rubella, measles, varicella, and the hepatitis status.
Do you actually find patients that have not been immunized for MMR?
I saw somebody today that wasn't immune to rubella. I mean, I think that they said their vaccination status was such that they received all their routine immunizations as a child, and they probably did. I guess for some people the vaccination doesn't take. But in cases like that, there is some debate about whether those people need a booster or not, but I recommended that they have a booster prior to, because we did have some time prior to going on immunomodulatory therapy. Does anyone else check?
The vaccination. Yeah, we do lately, you know, especially because of second-line therapies, you know, so like you all know, it poses a significant problem with vaccination. And the moment we have a patient now de novo, before we even start the therapy, as we investigate them for MS, we want to make sure that all immunization is up to date. and depends on the age, right? Younger women may have HPV vaccination. They have about 4 forms now. Older people may need Novavax. People who travel, they will need the cholera and other vaccinations. And it becomes a nightmare because most of them, like probably 50%, do not have their vaccinations up to date. And I'm surprised how many do not have hepatitis B. Many don't have Hep B vaccinations at all. And what else was
right?
Tetanus needs a booster every 10 years. A lot of them don't have tetanus boosters. And there's a mess with this vaccination. GPs are not doing their job. And the patients have a card in Ontario where they have their vaccination listed and when they were allowed to give them a booster. And some of them have them, keep them up to date, but over 50% don't have that. So then we have to go to GP and ask them for vaccination records. And we have to check them for all the things that Natalie has mentioned for immunization status. And then if you want to start them, you have to check for TB, you have to check for Hep C to make sure you don't have an indolent infection, as you know. But a vaccination is a horrible nightmare, especially as somebody with active disease that's on platform therapy, wants to do some aggressive therapy, and the vaccines are not to date. It's a nightmare of how you're trying to speed up their vaccination schedule, and when they have it or not, according to what you're going to put them on. So I think it's becoming something that we have to deal with more and more and more. We're trying to deal with them right from the beginning, de novo.
Mm-hmm. And I agree, and pneumovax is another one that even though we don't check for it as a blood test, many patients now are getting immunized with pneumovax against pneumonia before they start on therapy as well. Yeah.
Well, I agree completely with Draga, but the trouble is the community guy that doesn't have a nurse, it's very much more difficult for him to get all this done. It's a big deal. So,
and then how long are you going to wait to start therapy, waiting for all these vaccinations before the patient relapses? That's another issue.
It's definitely a challenge, and for some of the vaccinations, there are accelerated series. Like for example, Twinrex is typically given over the course of 6 months, but you don't want to wait that long to vaccinate somebody against hepatitis A because they might go to the Caribbean someday. There is an accelerated program for that that's done over a month. So sometimes there can be accelerated vaccination series, but it is a challenge, and certainly you don't want to start somebody on an immunomodulatory drug within 6 weeks of having a live vaccine. So that's one thing I keep in mind. So if you have something like Zostavax, you have to wait 6 weeks until starting therapy. So I would say that it's not uncommon that when we do go down the route of updating vaccines, that it does delay starting therapy by about 2 months. But sometimes if you have that time to wait, and it will simplify things down the road and open up a broader spectrum of therapies that you know are going to be accessible to the patient because they're already immunized, then it can simplify things long term. So we are trying here in Halifax to update the vaccination status as much as possible before starting on immunomodulatory therapy. But sometimes it's not possible. I mean, if someone's having an aggressive attack of a severe disease and they need to start Tisabri or another another higher efficacy therapy, then you don't want to wait 2 months to necessarily update all the vaccinations. So it's certainly a trade-off between what their clinical presentation is at the moment versus what would be useful to them to have as vaccinations down the road. Can be very challenging. I mean, I inherited a patient who is actually on rituximab and doesn't have immunity to a lot of things, but it's challenging to know what to do in that scenario because you're supposed to wait, you're supposed to wait in terms of the B cell depleting therapies until there's reconstitution of the B cells, which on average takes over a year, and certainly we're not going to interrupt this guy's therapy for a year to vaccinate him. So it's a challenge.
Dr. Parks, it's Stuart speaking.
Yeah,
so to cut in.
From the last vaccination.
Sorry, apologies. Just in the interest of everyone's time, we have about 10 minutes. So if you could move through this next section a little bit quickly, I would like to try to get to the discussion at the end. I know it's a good discussion. I want to be respectful of everyone's time.
Sure, yeah. In terms of the overall rating of how, like when you accumulate the results together, how neurologists rated the individual patients, the patient that they were assessing, 48% said that they had a patient that was low disease activity, 43% of the patients were rated as moderate disease activity, and even though platform therapies were being considered, 8% had high disease activity. So there was some discrepancy between neurologists in terms of what they considered versus moderate and high disease severity. So when asked, how many lesions would you basically consider low versus high disease activity, it was interesting because for some people, low disease activity was greater than 20 lesions, whereas for others, high disease activity was 1 to 5 lesions. So some discrepancy there among neurologists about what they consider low versus high disease activity. And, I don't think there's a specific threshold for like what definitely what definitely constitutes low versus high in terms of the exact number. But certainly I wouldn't consider 1 to 5 high disease activity, and I certainly, I probably wouldn't consider greater than 20 low disease activity. But
it depends where they are. So you have 3 in the brainstem, 2 in the cord, you're going to be high activity.
We're definitely going to get to that, but you're absolutely right. The location, whether it's infratentorial or spinal cord, definitely makes a difference. In terms of were they gadolinium enhancing, so some would consider some would consider having low disease activity even with 1 or more gadolinium enhancing lesions, whereas in other situations patients were determined to have moderate or high disease activity even without gadolinium enhancing lesions. But in general, gadolinium enhancing lesions would be an indicator of more severe disease activity. And then as you were saying, the location of demyelinating lesions in the brainstem, surprisingly, 51% of individuals rated an individual as having low disease activity, even though either brainstem or spinal cord lesions were present. And others rated, there were 19% that rated having moderate or high disease activity, even though those features of brainstem or spinal cord lesions weren't present. So certainly to me, having brainstem or spinal cord lesions would kind of raise concerns that they had moderate or high disease activity versus low disease activity, because both brainstem and spinal cord lesions are associated with worse long-term functional outcomes, so higher disability sooner. So in terms of the percentage, and this is basically just what was being shown in the graph. So among those patients that had brainstem or spinal cord lesions, as I said, it was somewhat surprising that 51% graded patients with brainstem or spinal cord lesions as low disease activity, but 78% felt that both cases graded as moderate to high disease activity had brainstem or spinal cord lesions, which isn't surprising. In terms of looking at whether there's been a relapse over the past year, so in terms of relapses in the past year, it was kind of 50-50 as to whether one relapse was considered mild or moderate to severe. Surprisingly, among those that had 2 or more relapses, 20% were still categorized as low disease activity, but not surprisingly, an increased number with more than one relapse were considered to have moderate to high disease severity. So again, that group that was considered to have low disease activity despite more relapses in a year, it's a little bit surprising. More than one relapse in a year would raise the suspicion of moderate to severe disease activity, and there's evidence to suggest that those people with multiple relapses in the first year do worse long term. In terms of recovery, not having complete recovery from symptoms was seen as more of a red flag for moderate to high disease activity. So 59% that didn't have a complete recovery were considered to have moderate to high disease activity. And again, surprisingly, that even though someone did not have recovery, they were still rated in this survey as having low disease activity. But again, individuals that don't recover completely from the initial attack, they do worse long term. So in terms of determining, I guess, disease activity, I look at relapses, progression, and the MRI, and certainly more relapses, higher EDSS score, and more lesions on imaging, particularly if they're infratentorial or spinal cord, or there's gadolinium-enhancing lesions. Those are all red flags for having more moderate to severe disease activity. So in the survey, it was also looked at what the reasons were behind selecting a particular medication from both the physician and the patient point of view. So the most common response by physicians was that they were taking into account what the patient wanted in terms of, but very much as a shared decision-making process. And then in terms of what patients were stating as their primary reasons, many, 55%, were stating that the reason they selected a certain medication was the safety or side effect profile. Second to that for patients was the mode of administration, followed by the efficacy of the medication. And so after patient preference, physicians' number one criteria for medication was the kind of the disease severity, disease efficacy point of view, rather than the side effect profile per se. So
sorry, I'm sort of jumping ahead just in the interest of time here.
So in terms of the discussion, patients had in mind that the safety profile, healthcare practitioners were very, very interested in the patient's point of view, but second to that had in mind the efficacy of the medication. And really, I mean, in my practice, it's as in many other practices, it's a shared decision-making process. And where there's so many options for disease-modifying therapy now, I think a general discussion of what's available is relevant, but it helps for the neurologist, I think, to narrow down as to what they think is appropriate in the clinical context, and then among a number of options, present those options to the patient, discussing the efficacy of the medications, the mode of administration, and the side effect profile, and come to a shared decision. So does anyone else have any comments on that approach?
No, I think that's what we all do.
Yeah. All right. And so moving on to the next slide, in terms of asking the question, what was your initial treatment choice? So this was based on the actual chart review results. So when you tallied up the patients that were included in the chart review, those that were graded by the neurologist as having low disease severity, actually the most common medication in the chart review that patients were started on was Aubagio. 32% of the low disease severity were started on Aubagio. 25% were started on Copaxone, and 21% were started on Tecfidera. So that's an actual reflection of the charts that were selected for this chart review. So how individuals with MS, how patients were actually treated within the past 2 years. So that's a reflection of current clinical practice among the 33 neurologists that responded. And then in terms of the patients that were graded as moderate to high disease activity, in the moderate to high disease activity group, so keeping in mind that the only individuals included in this study had to be on one of those medications, but those within patients on one of these medications, individuals who were started on who were believed to have moderate to high disease activity, 46% were started on Tecfidera, 22% were started on Copaxone, and 20% were started on Aubagio. So I guess in terms of how that breaks down, it's a little bit surprising that I guess 22% of patients with moderate to high disease activity would be started on Copaxone, since we know that that is one of the less efficacious drugs, and there's certainly more efficacious medications out there, particularly if you have moderate to high disease severity. So surprised about that. I mean, as far as the options presented, you know, Tecfidera has been shown to reduce relapses by 50%. Aubagio, it's in about the 40% range. All of the other medications are in about the 30% reduction of relapse range compared to placebo. So even though it's a little bit comparing apples and oranges because they're not exactly the same population of patients and it's not a head-to-head clinical trial, I mean, at least, you know, Tecfidera, I guess, at least as far as what the available numbers are, in absolute terms, you know, compared to placebo, has that 50% reduction, which makes it appear maybe a little bit stronger in efficacy than the others, although they're definitely not compared head-to-head, and so difficult to make that determination for sure. But certainly it was 46% of the treating neurologists started that when they thought that it was a moderate or high disease activity.
Thanks very much for that, Dr. Parks, and I apologize for rushing you through the end of that, but you did a great job presenting. So I'm just going to take 2 minutes now to have a few final notes here. So going back to the PACE-MS program for a second, there is a clinical audit tool available that it's optional, but it'll let you get credits from the Royal College, Section 3 credits, which are worth the most and they're the hardest to get. You can do that right on the platform, just opt into it, and then there's a program evaluation and a separate results review as well. Everything can be done on the platform VivoMap that you logged in to access this program. And then just final on the with respect to this share the learning exercise and what you'll be presenting to your colleagues, is there any, and I alluded to this earlier, what information can we use to supplement this presentation to make it richer, whether it's to support the discussions with your colleagues, strategies for patient conversations, whatever that looks like? Is there anything that you would suggest that we include in this presentation to make it richer for you?
Well, you made a big deal about exposure to opportunistic infections and vaccination status. So I think that it would follow that there should be some information shared about that. What should we be testing for? What should we be vaccinating for? Just sort of, because we don't have guidelines, we don't have a protocol, and as was mentioned, it's very hard for neurologists in the community to get this all done for their patients. If we're depending on
we can add that in.
Big delay in time, and we generally don't like to put people at risk of relapsing while we're waiting for family doctors to do immunization schedules and so forth. So I think that would be very important.
Okay, great.
Yeah, I think that's a great recommendation. I mean, it's hard to make absolute recommendations, but in general, I mean, it's important to consider vaccination against pneumococcus, and you know, at least locally, you know, what I'm testing for would be varicella, measles, rubella, and hepatitis, and it varies a little bit from individual to individual. For example, whether they want to get the hepatitis series completed or not before starting. But we can certainly, I guess, look into what additional information we can put in about vaccination status.
Anything else?
And I think, yeah, I think also to include the data that we have from the current up-to-date registries on pregnancy and any data that we have currently. There was a paper in Green Journal a while ago that not a single drug was saved in pregnancy, very safe. That was a while ago. So we need to have an updated information from the registries as to what do we know, what's out there. And understanding that not every pregnant woman on any of these drugs has been registered, but at least what we have.
Okay. Yeah, that's a good suggestion, and that was discussed before. We can include the pregnancy data and the registry information. Anything else? Okay, if there's no other comments, thanks everyone for your time tonight. I appreciate you logging in and taking time out of your evening. Dr. Parks, thank you for your great presentation this evening. And yeah, if you have any questions, feel free to reach out to us through Ashley, who's been communicating with you throughout the program. Thanks very much for your time.
Okay, thank you.
Thanks, Natalie.
Thanks. Thank you. Bye-bye.
Stimulated a great discussion, and I think that's the main point of a survey like this, is to see what our colleagues are doing, and then talk amongst ourselves to see maybe how we can educate each other and move forward.
And get more patients off Copaxone. Good night.
Thank you.
Thanks, everyone.
Bye now.